Welcome to Encouraging Wellness, where we shed light on the plethora of holistic healing and wellness methods so you can give yourself the power to ask why and become bigger than the condition you are dealing with or the illness you are currently fighting. Join Pamela Worth as she sits down with doctors, medical experts, healthcare practitioners, and those with unique healing stories to dissect groundbreaking practices that combine traditional Western medicine with alternative modalities. Hear conversations that empower you to go beyond hurtful stigmas, outdated practices, and unnecessary labels, guiding you towards a healthier and happier you. Here, we highlight your true worth and help unleash your inner courage. Now your host, Pamela.
Hi, this is Pamela Worth from Encouraging Wellness Podcast, and today I have Dr. Nasha Winters, and thank you so much, Doctor, for being with us.
What a joy, Pamela. You've got such an impressive story. It's so fun to be speaking with you and your tribe.
Yeah, well, Don introduced us and he just gave me a little bit of a glimpse into such an amazing individual you are. So tell us a little bit about your health and wellness journey, how you got to where you are, and then all the wonderful things that you've got cooking.
Well, one of the things I noted when we first got on together is I just love your brand, the encouraging wellness. Like there's so much about that just deeply gives me goosebumps even. It's very much resonates with me because I think I ended up in the space that I'm in. So for your listeners, I am a naturopathic oncologist. My specialty is integrative oncology and building bridges between the best that standard of care has to offer and the best that vetted integrative therapies have to offer. But my journey didn't start out just thinking that would be a really fun vocation, right? I wish, it wouldn't be that nice. But when I was 19, I had lots of health issues since I was born. And when I got sicker and sicker in the year 1990 into 1991, 30 some odd years ago now, which is kind of scary to say that out loud, but it is what it is. I just thought I was dealing with more of my chronic illness, IBS, endometriosis, polycystic ovarian syndrome. Later learned I had Hashimoto's. I also later than that learned I had celiac disease. I also was dealing with rheumatoid arthritis, all of these things at a ripe age of 19. And I'd had multiple injuries. I was a volleyball, star and, played in these realms that I should have been in my best physical condition for the type of training I did, but I just couldn't catch a break. Like I was constantly sick or injuring something and lots of issues. So by the time I landed in the ER, after going in and out of the ER for many months, in the summer and fall of 1991, I literally had a roommate who said, I'm worried about you. You're gray. Something's wrong. I couldn't take a breath even to walk across the room. And my belly, I thought I was just dealing with massive bloating because I'd had that all my life. By the time I got to the hospital, I was basically unconscious. My pulse ox was down to nothing in the 70s. So I had no oxygenation in my tissues. My organs were in failure. My liver and kidney were in failure. I had 9 months belly full of malignant fluid in my abdomen. I had that same fluid in my lungs and wrapping around my heart. And I also had a bowel blockage. Things had stopped moving. And so anytime I put something in, it caused excruciating pain or came back out. And so it was in that time that they finally did a proper workup and some imaging and some blood tests and realized I was in stage, at least the best they could suspect before biopsy, late stage ovarian cancer because of a grapefruit-sized mass on my right ovary, metastasis in my liver, carcinomatosis, which are basically all these little implants all over my abdomen and a lot of nodes inflamed in my pelvis. And so it would still take a few weeks to get the full results back from the malignant fluid they pulled out of my belly, as well as the tumor biopsy they were able to do at the time when I was in the hospital to give the confirmation of the diagnosis. But even by then they said with treatment, 3 months to live. But because my organs were so in dire straits, they said that they were afraid to give me any treatment because they thought it would kill me quicker. So that started my journey 31 and a half years ago, where I wasn't expecting to live, but I certainly wanted to understand how a 19-year-old, soon to be 20-year-old, I turned 20 at the actual time of the official diagnosis, October 21st, 1991, was the window in which they told me this, but I wanted to understand the why. And because I was pre-med and I had that kind of curious scientific mind, that was fascinating to me. But I also had an inkling that it had something to do with my environment, both the nature nurture component, some of the mental emotional components, even some of the toxicant exposures. And I suspected for a long time a lot of like dietary issues because of just my digestive history. So I knew there were a lot of components and I didn't think that there was just one thing. So I thought, well, if I'm going to die, I want to have an understanding as to how I got to this place. And I feel like that's been my journey ever since. And so I feel like I've been still doing that for myself for all these decades. And now the absolute privilege of doing that with tens of thousands of other patients. I no longer work directly with patients. Instead, I train their physicians. I consult with the doctor about their patients. I teach them the methodologies that I use to save my own tush and help thousands of other patients do the same, and built out a robust training program. We now have, to date, at the time of this podcast, 160 physicians from 16 countries, as well as 300 patient advocates from 16 countries. And we're building out a fabulous network that continues to grow exponentially. We do 2 cohorts a year in both of those. And we're also collecting data into a robust data platform, which is becoming an expert clinical decision-making tool for physicians, but also a front-facing side for patients for self-empowerment and awareness and understanding the why of their journey and where they need to go next. And then finally, we're building a nonprofit, one and only, first of its kind in the world, residential Integrative Oncology Hospital and Research Institute in your lovely state, in Southeast Arizona, actually south of Tucson, near Nogales, on a 1,200-acre giant regenerative eco-agriculture farm. So it's a big undertaking, but I've had a couple decades to be thinking about it, and here we are. That's how we ended up having this conversation today.
Wow, it's amazing. So, we haven't had a chance to talk about this ahead of time, but my mother is currently going through stage 4 ovarian cancer, stage 2 breast, and stage 2 colon. And
My goodness.
yeah,
All 3 individual brand spanking new, not related.
no, and she's had about 3 months to live for almost 5 years. And so we've gone through a number of different things. And interestingly enough, just 3 weeks ago, I took her down to Mexico because we've been going to a very, very well-known clinic in the United States. And they feel very specific about the course of treatment. And she just can't take any more chemo. She's been through so many. And she's done radiation. She's done so many surgeries. And so it's been a very interesting and eye-opening running through the things like the chelation therapies, the ozone IVs, the stem cells, the natural cancer killing T cells. It's been and you don't have to touch on this if it's too uncomfortable, but how much of what you're doing in terms of integrative oncology is allowed in the US, and how much do you have to kind of dance around and then potentially work with others that are, right outside the border? I don't know any other way to say it.
You're saying it perfectly. And I'm very comfortable to talk about it because it is what the condition you're describing has done in our culture in the United States is it's made us feel like we have to choose either standard of care or alternative. Mm-hmm. And that you either fall under a particular, therapeutic intervention that is FDA approved and insurance covered, or you don't, and you have to find the means to get the therapies needed to possibly save your life, right? It puts us in this terrible place because if you choose one or the other, you're going to have naysayers and deniers and haters on both sides of the camp, right? So both of them are going to think you're crazy. One's going to say standard of care is always bad. Ignore it. Don't ever do chemo. Don't ever do surgery or radiation. And then the other side is there's nothing to this witch medicine. These are just charlatans who just want to take your money. There's no evidence. Both are wrong. Mm-hmm. Okay, both are wrong. We shouldn't have to make a choice. We should be able to take the best vetted integrative therapies that have good evidence-informed data that have been utilized in other parts of the world that are part of the general medical system, okay, that are part of the approach to care there, as well as looking at standard of care from a more individualized, precision-based way that can be done way less toxic, with way less toxicity, and in a particular dosing and methodology that allows the patient to push back the cancer while supporting their healthy terrain, their healthy body. That should be standard of care. What I'm describing should be what everybody gets all the time. And so you have a really good example of this. So we just completed in the United States a phase one. So phase one clinical trials, for you and your listeners, if you don't know, there's three major phases to clinical trials. First phase is safety. That's all they're looking at. Does this therapy kill you? That's all they're looking at, right? They're not looking at is how long is it going to keep you alive? They're literally looking at, is it safe enough for you to take? That's a phase one trial, which really doesn't tell us anything about how this medicine works. Phase two clinical trial is what is the proper dose to achieve safety, right? Like basically, how much can we give you until we take you past the threshold of safety that may have a clinical impact? Phase three then is when we start to look at overall survival rates and progression-free survival rates, and we actually start to look at its therapeutic application. So what I try to explain to patients is, of course, we need these clinical trials, but the way they're structured, personally, I do not want to donate my body to science until it's into a phase three, right? If I've got some time on the clock, I'm not going to jump in to just give somebody some about a safety profile, right? That's not going to save my life, typically. Yes, those things can happen. We need those, but we can also be doing our research better. And that's for another conversation here in a moment. But here's an example in the United States. We have a therapy that's been used consistently in the same method and approach since 1917. It is, if you live in Germany, Switzerland, or Austria, and you have cancer, you have an 85% chance to use that therapy at some point during your standard of care. If you live in the rest of Europe, you have a 65% chance of using that therapy. If you live in Canada, India, or South America, that is in your medical registry. So it's a therapy that you can get dispensed from your local pharmacist. It may not be covered by your insurance model, but it's dispensable in your own country. And this therapy is also the most studied integrative oncology therapy on the planet, and it is mistletoe therapy. Okay, so I love your head's like, what? How do we not know about this therapy? Maybe this is the first time you're hearing about it. But in the United States, in 2014, I spoke at a global international symposium on mistletoe therapy. And at that gathering was a whole group of doctors and patient advocates from Johns Hopkins. And they were all there because they were interested in starting a safety trial on mistletoe therapy. Now, there are over 2,000 published studies on mistletoe therapy globally. There are 250 what would be considered RCT, very high quality studies out there in the world. But because they were not done on US soil, and because we did not do the phase one or phase two, they basically ignored or disregarded all of the other information. That conversation started in 2014, and I helped them rewrite their IRB to apply it as an intravenous application for folks with stage 4 solid tumor cancer types. And that therapy, this is 2014, these conversations started. That clinical one trial, that phase one safety trial just completed and just got published. Here it is in 2023.
I mean, it's terrible.
It's ridiculous. It's ridiculous. And so we actually have a book that came out this past year November 2021. So a year and a half ago now, called Mistletoe and the Future of Integrative Oncology, which goes through the deep history, the deep dive, the references, the mechanism of action, the scientific validity, as well as loaded with the case studies that are out there on this therapy. Because we thought, well, the average time it takes for a study to get from the bench, which is that sort of phase one trial, to the bedside to actually help a patient is 17 years. They call it the 17-year gap. Right? So we were hopeful that this phase one clinical trial might rush things. It's not. The FDA is now going to make us go through and do phase two. So waste another $1 million in another 10 years to go through and say, yep, we can give them at this dose, when the rest of the world has been using this therapy successfully since 1917. So to your point, it's freaking ridiculous. I'm not really good at mincing words, that we have to go this route when we have what's known as evidence-informed therapies, meaning there are a lot of people using these therapies successfully in other parts of the world. Why do we have to go through the same flaming hoops? So we have patients that are willing, like your mother, to travel out of this country to get access to therapies that are not available in this country, such as, they might be available, but they're underground. and they're very expensive, right? And they're often still not partnered in ways, they tend to be in really fringe clinics where they're also not bringing in the best of what standard of care. They're not doing the labs, they're not doing imaging. They maybe aren't bringing it together with other therapies. So you miss out on an opportunity, which is precisely why we're building this hospital and building this database. But for things like hyperthermia, for instance, to get the proper type of hyperthermia that actually has a high enough heat to actually kill your cancer cells, you cannot get that legally in the United States. You have to go beyond. And these therapeutic interventions are made in Germany. They're German technologies, Oncotherm, Heckel, Celsius 42 are some of the devices. They are available, those devices are available in Canada, and they're available in Mexico, and they're available all over Europe and Southeast Asia, but they're illegal in the United States. Now, there are some forms of hyperthermia in this country, but they're different form. They are local regional, they don't do the whole body, and they can do a little bit of what we call abscopal immune modulating effect, but they don't directly kill the cancer. And so this is the place where it's like, how can we do better? And that's what leads us to these conversations. So to your point, yes, there are sadly a lot of therapies that really do have efficacy, that have good data, that have good, not just anecdotal, but actual clinical trials, but just because it hasn't been done on this soil and we haven't given our stamp of approval does not mean it's without merit. And so now it pushes our patients to have to make a decision of an either or even to leave the comfort of their own home, their own community, their own country to achieve results when all else that's being offered to them in the United States is failing. And so that's what we're trying to change. There's a new law that came out a couple of years ago called the Right to Try Act. So it is allowing some of these therapeutic interventions now sort of somewhat legally, at least no longer labeled as illegal in the United States, because when patients have exhausted all that standard of care can offer, there's these sort of compassionate use opportunities, both in standard of care, off-label drugs, and integrative therapies. But we don't want people to have to wait until they're literally at death's door to have access to these things. So this is why you and I are trying to educate the masses to know that we can do much better, and to build a hospital that's under a giant, investigation review board, which is known as an IRB, to get us proper channels of research for safety and efficacy and, patient and, informed consent. That's what we're building here, so that we can do a lot of these therapies under one roof that are normally not allowed to be done in the United States. And to do so in a nonprofit environment where we have funding from research grants, philanthropic donors, and scholarships, and a cost sharing model that allows this to be more accessible to folks that otherwise wouldn't have the resources to get this kind of care.
So, which is
a lot to unpack.
Yeah, incredibly exciting. So when is the hospital going to be ready? How far is that?
So we have the land donated.
Yeah.
We have the plans. Everything's ready. We have our pro forma. Mm-hmm. We have 3 phases to this. So phase 1 is getting all the final permits and the engineering and all of the things that are so we can actually put the shovel into the ground. And that first phase is $6.5 million. So we're now in a capital campaign to raise the $6.5 million. The next 2 phases we hope to have done within 2 years beyond that point, which is another $120 million. This is not cheap, but we're building an 80-bed, 250,000 square foot hospital, research institute that has its labs, that has an entire hyperbarics center, it has an entire pediatric oncology, integrated pediatric oncology wing. It has it's got all of our food. We grow all of our own food here. It's completely green, off the grid. We're hardwired, so we're mitigating EMFs. It's got every detail has been thought out, that even up to the mattresses are organic, right? Because if you go to a hospital or clinic anywhere, you're going into a toxic cesspool. Like, they're such toxic environments. There's so many infections that come from hospitals, from the venting systems that are like loaded with aspergillosis and, mold and whatnot. We're going to all the lengths with building a truly clean and green and health giving versus health taking environment. And we're showing people how to live healthy on a healthy planet. But when you look at that 127 million overall price tag, when you look at the average cost it is today to even remodel just a wing at MD Anderson, as an example, those are usually upwards of $200 to $500 million projects.
Isn't that wild?
So everyone's like, oh, 127 million, that's a lot. Well, we're not a spa. We're not a clinic. we're a freaking hospital. we're like, this is what it takes to build a hospital. And we're doing it in also a very responsible way because we're not doing billing for insurance. We eradicate almost 50% of our overhead just by not having an insurance billing department. I mean, just to give you the top 10 most financially successful hospitals in the United States, 7 of those 10 are nonprofits. I know, right? And so when you look at their numbers, you're like, how is that? Because a nonprofit has certain like tax benefits, but they also have a responsibility to give back into their communities. And when you really look at it, they might be giving back into their communities, but they have such massive overhead to keep the machine going that there's very little left at the end of the day to go back into the communities. So we're really even revamping the nonprofit model so that the lion's share of our revenue goes back to help other patients get this care and help our community around us, and keeping our overhead incredibly low and incredibly efficient and effective.
Oh, that's super. So how in the world did you decide Southeast Arizona?
I love this question. So about 30 years ago, so maybe a year and a half into my process, when I'm suddenly finding myself still alive, not expecting that, didn't try to make that happen. There's a whole nother story we could go in there, but I started having what I best could describe as sort of downloads or visions or dreams, that I started seeing this place, and I started seeing this place in the desert. I started to understand this, and I realized that for me, the desert holds so much metaphor. Because most people, by the naked eye, you look at the desert and it looks very dark, very like just dead and dry and inhospitable. But you give it just a tiny bit of resource and it comes alive in the most miraculous way. And it just like I get so enlivened by just the tiniest amount of moisture that hits the desert, and the smell of chaparral and the vast, beautiful skies and how everything comes alive. To me, it's such a metaphor for who we are. So that's one piece. The second piece is there's only 3 states in the union that have very broad scopes of medical practice: Arizona, Nevada, and California. No one wanted to live in Nevada. I'm sorry for my Nevadians listening to this. And California, the bureaucracy, the cost of living, all of the flaming hoops we'd have to go through to do this, it would never happen. Arizona is a bit of a renegade, a little bit of a rebel, right? A little bit of the Wild West. So there's that. It's also one of 7 states that does not go through years of permit processing to build a hospital. My dog could literally just go, I'm building a hospital. Arizona is one of those places. We also very much needed land. And we needed lower cost of land and lower cost of people to help us run the land. And that is something that Arizona also offers. We also are in a state, in that part of the state has a lot of socioeconomic depression. So we wanted to bring jobs. I mean, we're expecting to bring about 1,200 jobs to this region. So we want to bring in really good jobs. We want to do on-the-job training for med techs and for organic farming and for solar power and for culinary arts, because we'll have a culinary school, and like hospitality, because there will be a destination wellness component on the campus that's for profit. But then there's the nonprofit hospital, and those for-profit entities will also help shore up the financials for the nonprofit. And so there's a lot there. And then also, frankly, the proximity to the Mexico border. And so having that I've worked in clinics. I worked in a clinic in Sedona many years ago, where literally I was working a clinic shift that day when the DEA and the FDA came in with battering rams. You're talking people pushing around like enema bags that are like withered and sad and sick. And they come treating us like we're the cartel, for crying out loud, and like break down the door and shut down the operation, even though it was an environment that was a clinical research environment. So we want to have the proximity that if for any reason, anytime they get a wild hair and they attempt to do this, which we're pretty good in our legal and our informed consent and the things that we're building here to know that probably won't happen. But if it does, we are setting ourselves up to have a sister campus on the other side that we could have continuity of care to just shuttle people right across the border. So we've created nice relations with the community in and around Nogales. And so those are things that have been building forever. There's also, I went to naturopathic medical school there. My husband went to Arizona State University. We have a great relationship with U of A. We have a great relationship with medical schools. We have a great relationship with the academic institutions and the research institutions. And in the state of Arizona, MDs can practice homeopathy and acupuncture. Naturopaths can deliver deliver babies and give chemotherapy. Acupuncturists can dispense medications. I mean, it's very inclusive. And so it's a state that really lends itself. And we also needed an area where we had easy access to an international airport year round, that we also, because it sits at about 3,200 feet, we're at what they call high desert grasslands. So it still can get hot in the summer, but in the 90s versus 120s. And it has a beautiful year-round growing season. So those are the reasons. And I love that you gave me the opportunity to speak about that, because it does really lend itself to an ideal place to have this type of property. And being someone who was in Durango, Colorado, which I loved, and I had a lot of people willing to offer land for years, the temperature, when you're a cancer patient, you're cold. Okay. It's actually considered cold disease. And so coldness is really constricting and very difficult for the body to overcome. And so that just can wear on you there as well. So we needed something that was more temperate, but also elevation. So even though I love my beloved state of Colorado, for most patients dealing with cancer, their red blood cell counts are low because perhaps their standard of care therapies or just the cancer itself, or they've got issues going on with their lungs from their cancer therapies. And so it's dangerous for them to be at that elevation, especially if they aren't living there and accustomed to it and they're coming in to visit. And so we've tried very hard to literally think about everything. When you've got 30 years to dream on this, you do think about everything.
No, I think it's wonderful. And it really is a beautiful part of the country. It's a little bit off the beaten path, but it really is a neat place. Gosh, so many things to ask. So for someone listening that either themselves or a loved one is going through a cancer, do you have, a handful of things that you're like, look, this is super, super important to really make sure that you're thinking about or doing or calling or researching or asking more about, or, just kind of some tips and.
Absolutely. Well, first of all, thank you for that too. And on my website, Dr. Nasha, drnasha.com, there's a little freebie handout, which is called 5 steps. Okay. And it's like, basically, if you're newly diagnosed or newly diagnosed with a recurrence or progression, right? And you're like, what do I do now? To your point, it's like, first of all, the number one point is to breathe, right? Just pause and breathe. And this is really critical, because unless you have a cancer, which is very rare, by the way, unless you have a cancer that's creating a medical emergency, like it's obstructing something or it's necrosing into vasculature, or it's eating into a bone. And, it's like suddenly you've got a major break or a major collapse or a major organ involvement. Those aren't, otherwise cancer's not a medical emergency, but the diagnosis often is. And by that, it sets off all the alarm bells. No one wants to hear, I've got the big C, right? That is like, takes you right into post-traumatic stress disorder right there, amps up all the sympathetic nervous system pieces and kicks off all kinds of growth signals, by the way. So breathing is critical, because you want to try and maintain some homeostasis, get yourself into parasympathetic as quickly as possible so you can think clearly and be responsive versus reactive from this point forward, because it's in these first moments that can make or break your diagnosis. And it's in these first moments is that also often sets patients up to unfortunately come back and see me again in the future when they have a recurrence, because of the way they manage their first rodeo. Right. And so if folks had the opportunity to get this download, know these 5 things, like stop and breathe. Number 2, at the time of my diagnosis in 1991, there was no Dr. Google, there was no internet. And in some ways, I think that benefited me, because today the resources are overwhelming. The information overload, the everyone knows someone who does something, right? And who did something. And so suddenly the paralysis by analysis sets in, the overwhelm, the thinking you have to take everything, the reactivity of it all, the well-meaning but unsolicited advice from everyone will make you want to run and hide, right? Like, I so understand this place so well. And so in that, we also want you to take a moment to get second, if even third opinions from different institutions. Okay. Because if you're asking in the same building, they're all going to tell you the same thing. They're talking to each other every Friday at grand rounds. So if you're asking, well, I'm going to ask a different doctor in your department, they're going to tell you the same, because it's a good old boys club. They're not going to step on each other's toes. So do get your resources elsewhere, but also start to conduct your team. Know that your oncologists are experts at the tumor. They are not experts at the terrain. And by that, I mean everything else that's wrapped around the tumor. Okay. And you need someone who understands that and can put the pieces together. So you want to be creating, you are the CEO and you want to put together your board of advisors, right? And so your oncologist is a board of advisor. You are your therapeutic nutritionist, maybe your naturopathic doctor, maybe your rabbi or your priest, maybe your, whatever resources come on your board, you want to put that together. And then you want to do what my methodology is test, assess before you address and never guess. And so jumping into saying, I'm going to do X, Y, and Z. Well, you need to know, does that X, Y, and Z fit? Like you're being offered this drug cocktail, this pharmaceutical standard care cocktail, but do you even have the targets to treat with that drug? Like they're wanting to give you maybe Avastin. Well, do you have a VEGF, a vasoendothelial growth factor target for that drug to actually plug into? And if you don't, then that drug is completely a waste, right? So these are the examples and even down to your alternative care, like how does somebody choose when you go to a place like Mexico, or like how was that treatment chosen for you? Because one of my biggest pet peeves are protocols. I am not a protocol doctor. I'm a person doctor, and I don't treat cancer, I treat people with cancer. And so I work very hard to understand the terrain in which the cancer grew. So I know how to support that soil and change the environment, because plucking it out of the soil, like, slash burn poison, chemo, radiation, surgery does not change the soil, folks. In fact, it can make it worse and make you more vulnerable to recurrence or progression. And so those are the things we do together. And so those 5 steps buy you a lot of time to realize you've probably had this on board for at least 7 years by the time it gets big enough and loud enough to capture your attention. So what's a few more days, weeks, or months while you put together your team, gather your information, do the right testing to know the right approach at the right time, at the right dose. And it may be a little bit of everything. It may be all standard of care or all alternative care or a lovely combination of the two, but it needs to be based on you, the N of one. And that's what we're designing. That's what we're creating. And that's what we expect standard of care will be someday, and what we're actively trying to build.
Well, thank you. I really appreciate that. So again, for people that want to find you, doctor.
Yeah, have them come. So probably the best place, because it gets you to all of my sites and it gets you to the book and the handout. It's called mtih.org. And that stands for Metabolic Terrain Institute of Health. .org. That's the nonprofit hospital piece, but it takes you back to the Dr. Nasha site. It takes you to the books. It takes you to the explanation of what you and I talked about. It gives you that handout for the 5 steps, where to start. It also gets you into our newsletter and gets you involved on how can you maybe volunteer for this? Like, we're always looking for help. Maybe you have someone you want to have an honorarium or a memoriam to, that you could donate on their behalf, to help patient grants or patient education, or even the physical build out of this hospital. We're always looking to build our board of advisors. We're always looking to bring in people into our training. So physicians who want to learn these things, or patient advocates who want to learn these things. So there's a lot of different ways in which you can get involved in a big way or a small way, and every single drop makes a difference. Do not ever underestimate the power of one grain of sand or one drop of water. It's what makes the entire ocean, right? So let's do it together. So yeah.
Well, thank you so much, doctor. We really appreciate having you on today.
Thank you so much, Pamela. What a joy.
That's it for this episode of Encouraging Wellness. We hope this serves as an eye-opener to you on new ways to approach your health and wellness. By learning both unique and the best alternative wellness and healing methods, you can live your best life. Listen to more of our episodes at www.hello.health. Be sure to subscribe to the show and leave a rating. Together, let us work towards unlocking you and your family's best self. Thank you for listening. See you on the next one.